So this is the like part two, starting with the question like point 92. So the point 92 is saying the hemophilia is occurring after the transfusion of packed red cells. See, whenever we are giving the transfusion, so during the transfusion we have to give the what thing, immunosuppressive agent. What is immunosuppressive agent? Like steroids. Okay, the steroids here we will be examples of the steroids, that is the prednisolone. The example of the steroid is prednisolone. So remember this condition, and also remember hemophilia. We have discussed the hemophilia A, B, and hemophilia C. So this is what hemophilia A, hemophilia B, and hemophilia C. Tell me which factor deficiency.
Hemophilia में तो भाई factor 8.
Yeah, 8.
Factor
B for factor 9.
Yeah, and factor
11C.
11. Okay, so we have the 8, 9, 11. That we have the 8, 9, 11. These are the hemophilia factors A, B, C. And which is the Christmas factor?
8.
8.
8. Okay, Christmas. So remember that these are all are the X-linked recessive, whether it's hemophilia A, hemophilia B, hemophilia C. And remember, they were the APTT will be increased. The APTT will be increased in case of hemophilia A, hemophilia B, and in hemophilia C. Okay. Then you have the type 1 diabetes mellitus. If you see, there will be the hyperosmolar, means osmolarity is very, very high. So if the osmolarity is very, very high, what we call this condition? More than like 50 osm per liter, more than 33. If more than 33, we call this as the milli-osm per liter. We call this as the hyperosmolar. So in this condition, there is patient if have the type 1 hyper diabetes mellitus, hyperosmolar. So this is case of the high hyperglycemia without ketonemia. The ketonemia, remember the ketone bodies, they are acidic in nature. So if we will be seeing there is a fruity smell in the urine. So if you will see the fruity smell in the urine, we can consider it as the case of the which condition? Ketosis, diabetic ketoacidosis. What is the treatment of diabetic ketoacidosis?
Insulin or rehydration.
Insulin. Which is the drug of the choice for the diabetic ketoacidosis is what? That is the insulin. Now see, if the playing with the a child is there playing with the playpen. So, okay, playpen is what? That is a foreign bodies. Suddenly developed the paroxysmal cough. So if any foreign bodies and the child developed sudden cough, sudden paroxysmal cough, and there is a respiratory distress, dyspnea is there. So what you have to see, what you will consider it as the foreign body in respiratory tract. Now tell me which is the most common foreign location for the foreign body.
Right side.
Right side is which one?
Bronchus.
Which bronchus? Right bronchus. Okay. Why this is the right bronchus?
Wide होता है भाई वो.
Okay, so this is you have to remember which is the most common for the right bronchus. So this if you see the anatomical structures of the right main bronchus, so it will be whenever will the any foreign body, the mostly it is the like wider and it is the shorter as well. Okay, and it will be the more vertical due to vertical effect, vertical composition. So due to that gravity effect, it will go directly to the right main bronchus compared to the left main bronchus. That is very rare, but the more common is what? That is the right main bronchus. Right main bronchus. Then we have the dilated cardiomyopathy, and we see the blowing sign. Urine is decreased, liver like size increase, that is the hepatomegaly. Mechanism of edema developed. So in case of the dilated cardiomyopathy, what you will see the venous congestion of greater circulation. What is the venous congestion of greater circulation? Firstly, tell me what is greater circulation? What is greater circulation?
भाई वो जो deoxygenated blood जाता है वी से ऊपर.
So we will be seen in case of venous congestion क्या होता है?
इसका एक congestion हो जाएगा, जा नहीं पाएगा फिर.
Greater circulation basically we have in that main systemic circulation. ठीक है, systemic vein. So venous congestion, what is that? The blood pooling will be there, and due to that blood pooling, you see the increased pressure in the systemic vein. Or mostly we will see the vein that is present outside the lungs, and that is involved in case of the general circulations. It usually why it occurs venous congestion, greater circulations due to right-sided heart failure. When the right ventricles will not able to pump from the right ventricle, which artery will rise? Pulmonary aorta.
Heart.
You know, if you see that we will be having
Pulmonary.
pulmonary aorta. So we will be having heart. See, this is basically we are having the heart. So we will be having the right atrium, right ventricles. Then we have the left atriums and we have the left ventricle. From the right ventricles, which aorta rising? That is the pulmonary aorta. And this will go to the which where into the lungs. Okay. From the lungs, which vessels will come?
4 vessels.
Which 4 vessels?
Pulmonary.
4 pulmonary veins will come. 4 pulmonary veins will come. And what they will carry? They carry the oxygenated blood. Usually pulmonary system carry the deoxygenated blood, except we will be having the pulmonary vein that carry what? Oxygenated blood. From the then blood will come to the left ventricles, and from the left ventricle it will go to the aorta. Okay, the aorta carry what? Oxygenated blood. From then aorta it will carry the blood from heart to the body, and now from the body it will come to the right atrium through the superior vena cava and through the inferior vena cava. What they carry? They carry the oxygenated or deoxygenated? That is carry the deoxygenated blood. They carry the deoxygenated blood, and this deoxygenated blood will come into the right atrium, the right ventricle, then go to the pulmonary aorta, and that's why this circulation will occur. Okay, so the patient if having the what is the edema development, the cause of edema development, what we will be having, that is the venous congestion of the greater circulations. What are the key signs that you are going to see in this condition? If we will be having the venous congestion of the greater circulation, venous congestion of greater circulation. Okay, the venous congestion of greater circulations, this is basically mainly due to right-sided heart failure. So what you will see? You will see first of all jugular venous distension, JVP sign. That is the distension of jugular vein. Jugular venous distension. What does that mean? That means you have the bulging neck vein. The neck vein will be bulge out. So that is the bulging neck vein will be there. Along with that, you see the peripheral edema because of the congestions, blood pooling. You see the edema. Edema is what? Basically the fluids that will accumulated, and that is the swelling. So there will be the swelling of the legs, swelling in the ankles. So this is basically we have the peripheral edema. Then we will see the hepatomegaly. The patient will be having the hepatomegaly, the increase of the light. And if this fluid accumulated in the abdomen, what we call this condition? What if
ascites.
Ascites. That is the fluid in the abdomen. So this is what we have the venous congestion of the greater circulation. What is the cause of that? The cause is the right-sided heart failure. Here you will see the urine will output decrease, liver will increase. What is the mechanism of edema development? That is the venous congestion of the greater circulation. Okay. If we are having the diagnosis of the mitral valve prolapse, so what you will go? Echocardiography. In the option, there are the both option ECG and echocardiography. So you have to, if they have put the hard work, you also have to put the hard work. Okay, if they have written ECG, then you are then written echocardiography. Who takes more time? Echocardiography.
Echo. भाई ये क्वेश्चन कहाँ पे है? मैं एक बार बता दोगे, मैंने क्लासेस मिस कर दी थी.
बेस में
2014 वाला भाई.
हाँ. So but usually this type of questions not come in the exam, but exam के अंदर थोड़ा सा मतलब they make it clarify, and after that the few questions you can get sometimes 2 or 3 questions in which you see some controversy. Okay. Rest are direct questions. Hypoxia, Morose and Babinski. Which tell me with the Morose and the Babinski reflex. This is present in hypoxia intracranial. Intracranial, you see there is a decrease in oxygens. Plus you see the Morose and Babinski reflex. Morose and Babinski reflex in is Morose and Babinski reflex seen in which condition?
Hemorrhage.
Which one?
Subarachnoid hemorrhage.
Subarachnoid hemorrhage. Okay. What you will see in the Morose hemorrhage? This is also known as the startle reflex. This is also known as the startle reflex. Okay. So basically we will see the Morose reflex and we will see the Babinski reflex. We usually will see in case of the newborn. Okay. And then normal up to which year? Like if you see Morose reflex, that is around seen in the 4 to 6 months, and Babinski reflex, it's seen up to 1 year. What is Morose reflex? Morose reflex is basically like when baby baby feels like they're falling, or when they hear a loud sound, so they spread out their arms and spread their finger, pull their arms back in. So that is all this what Morose reflex. Babinski, what you have seen when you stroke the sole of the baby foot. Okay, so the big toe will move upward and other toe will fan out. So that is what positive Babinski reflex. And they help in the assessing the neurological development. So in this condition, we will be having like there is hemorrhage condition will be there. So that's why we will consider it as a subarachnoid hemorrhage. Okay. Then we have the B attack. The B attack will cause but which kind of hypersensitivity?
Type 1.
Type 1 allergic.
Type 1. So we will be having the desensitization by means of the B venom. So that is what type 1 hypersensitivity basically. Then we have the bronchoectasis. The bronchoectasis will be seen in which condition? Cystic fibrosis. Plus we see the watch glass near deformities. So what are the tactics will be there? There is a dilatation. What you will see in the bronchoectasis basically, the bronchoectasis, you have the dilatation of the bronchi and the bronchioles. And the abnormals bronchus will be there. So that will be the bronchoectasis. The bronchoectasis we know that is seen in condition which condition? Mucoviscidosis. What is mucoviscidosis?
Cystic fibrosis.
Cystic fibrosis is also known as the mucoviscidosis. ठीक है, तो bronchoectasis में क्या होता है हमारे पास? Chronic lung disease है. Permanent क्या हो जाता है यहाँ पे? Permanent क्या होगा? What will occur permanently? Abnormal dilatation of the
Dilation.
Okay, large airways का क्या होगा? Abnormal dilatation होगा. What is the main cause of that bronchoectasis? You will see in the question the patient will be having the repeated infections like pneumonia. If they say repeated infection like pneumonia, cystic fibrosis, some immune deficiency are there, and any obstruction are there that causing the dilatation of the abnormal dilatation. So they all are the main causes of what bronchoectasis. What you will see in the bronchoectasis, you will see productive cough. The patient will be having the productive, so loads of the sputum, mucus secretion will be there. Along with that, the recurrent chest infection. There will be the recurrent chest infection. That's what or we can say the repeated infections like pneumonia will be there. And due to if there will be having the repeated infection, the pneumonia. So pneumonia, we will see the crackles. Or if any obstruction are there, there is a high chances of the wheezing. And this is the watch glass nail. What does it mean? Watch glass nail. Thickening of the fingertips. Thickening of fingertips. So what is that? Clubbing. That is known as the clubbing. Okay. So so what will use as the tactics? We will do the surgery in such condition to make the to narrow down and make it possibly not make it abnormal. But this is the permanent dilatation. The one more thing. The bronchoectasis, where we see bronchoectasis in Carter-Jenner syndrome. What is Carter-Jenner syndrome?
Sinus invertus or primary ciliary dyskinesia.
Primary ciliary dyskinesia.
Ciliary movement or dilatation.
So what triad will see?
Bronchiectasis, sinus inverticus.
Chronic sinusitis. ठीक है, situs inversus. As well as what we will see, there will be. Bolo, which one?
Situs inversus.
अरे same
Bronchiectasis.
Bronchiectasis. ठीक है. So उसके बाद what we have seen in the lungs, what other lung pathology we have studied? We have studied about the lungs pathology. The lungs pathology we have studied about the restrictive lung disease and the obstructive lung disease. So in restrictive lung disease, what will affect it? बोलो. अरे inspiration. The inspiration will be affected in restrictive lung disease, and obstructive what will happen? What will affect it?
Expiration.
Expiration will be affected. Okay, there will be the obstruction will be there. What are the examples? Like we have the COPD, chronic
Okay.
obstructive pulmonary disease. COPD includes
Asthma.
like we have the asthma and chronic bronchitis.
Right.
Okay, and what other conditions we will be having? Pulmonary emphysema. Pulmonary COPD, that is again the COPD, pulmonary emphysema. Okay, so this one will be having the obstructive. Restrictive, we will be having the
Coniosis.
pneumoconiosis. What is the pneumoconiosis? B for
Occupational
bag.
disease.
Okay, tell me bagosis. Bagosis is due to and bacinosis is due to
Bagosis, sugar.
Sugar cane. और बाइसिनोसिस ये कॉटन
औरों को
फैक्ट्री.
बोलने दे थोड़ा धीरे, उनको भी थोड़ा करने दे. Bagosis and bacinosis, बताओ.
Bagosis is basically sugar and
And
bagosis is
bacinosis?
cotton.
ठीक है, कॉटन. इसको रिमेम्बर दिस दिन G4 गन्ना. ठीक है, G4 गन्ना. तो गन्ना में क्या होगा हमारे पास? सुगर केन. ठीक है, तो G4 गन्ना, गन्ना फॉर शुगर केन. तो शुगर केन के अंदर क्या होगा? शुगर केन फैक्ट्रीज के अंदर अगर कोई बंदा काम करता है, if the person is working in the sugarcane industry, they will be having the bagosis. And the bacinosis, you can remember C4, S for C, cotton. ठीक है, you will never forget, remember the G4 गन्ना is known as the sugarcane. ठीक है, other thing, what is the pulmonary emphysema? क्या होता है? In which you will see the red index. What is the red index? What is red index? बोलो. What is red index? तो इसमें क्या होगा? Increase of the mucus. What is the normal red index? That is 0.4. That is the 0.4. ठीक है, red index increase in which condition? Red index increase in which condition?
Bronchitis.
In case of the chronic bronchitis. And it is normal in which condition? Asthma. ठीक है, asthma we will be having the normal conditions. After that, if you will see, there will be having the bronchial asthma. There will be the, what you will see? Three things. Bronchial asthma. What are the three things you will see? Corolla bodies, Krusman spiral, and Charcot Leydig cell. ठीक है, Corolla bodies, Krusman spiral, and the Charcot Leydig cell will be there. अच्छा, ब्लू ब्लोटर्स किसको होता है? ब्लू ब्लोटर्स.
ये ब्लू ब्लोटर्स तो भाई ये तो मीजल्स और उधर नहीं रुबेला में नहीं चला गया, ये इधर भी होता था.
Any other blue blotters? Blue blotters and pink puffers. ब्लू ब्लोटर्स में क्या होगा? साइनोसिस. तो साइनोसिस हमारे पास किस में देखने को मिलेगी? इन केस ऑफ नो chronic bronchitis. Chronic bronchitis, you will see the due to obstructions, long obstruction, you see that there will be the blue blotters. And pink puffers, balloon like, you know, so they will be in case of the pulmonary emphysema. Pulmonary emphysema. The pulmonary emphysema, you will see the pink puffers. So because there is entry of oxygen, then retention of the carbon dioxide, but there is no cyanosis will be. Okay, so that will be having the emphysema. So what is the emphysema? There is the irreversible enlargement of the air spaces that is distal to the terminal bronchioles. Okay, what will be, which enzyme deficiency will seen in emphysema? Which enzyme deficiency will seen in emphysema? Alpha 1
Alpha
anti
antitrypsin.
antitrypsin deficiency. Alpha 1 antitrypsin deficiency seen in case of. And this is what it is, anti-elastic. This is anti-elastic. देखो, it will never lose the elasticity of the lungs. If this enzyme will be deficient, the lungs will lose its elasticity. And if the lungs will lose its elasticity, which hormones will increase? Increase of elastase. This if enzyme will deficient, there is an increase of elastase enzyme will be there. And if there is an increase of elastase enzyme, what will be there? It will cause the destruction of alveolar wall. It will cause the destruction of alveolar wall. And if the destruction of alveolar walls, the lungs will become puffing lungs. Like you have the balloon like they will lose its elasticity. And if they lose its elasticity, then it will call the emphysema. So in emphysema, the destruction of the alveolar wall, and the risk factor for this condition is the smoking. Same for we will be having the chronic bronchitis. That is, smoking is the risk factor. Okay, which is the types? If they say center acinar, the center acinar type is the most common, in which upper lobe will be affected. Upper lobe will be affected, and the center acinar will be very, very common. So we will be having, then we have the question number 99 we have. So there is the bronchiectasis. What you will do? The tactics of the surgery. The same like we have seen that there is cesarean section will be there. So the cesarean section, like we have seen in the obs gyna, the most preferred is what the cesarean section do. So same like in the surgery, most of the questions, what you will get what? The surgery. Okay, you will in the options you will get the surgery. So mostly if you don't know anything regarding what can be the answer, if surgery in the options, go for the surgery. Okay, for the Krok questions. Then we will see the TOF. What is the tetralogy of fallout? What you will see in the tetralogy of fallout?
4 defects मिलेंगे भाई.
4 defects we will see.
भाई पहला तो राइट वेंट्रिकल हाइपरट्रोफी और वेंट्रिकुलर सेप्टल डिफेक्ट और एक पल्मोनरी स्टेनोसिस और एक वो ओवरराइडिंग ओर्टा.
ठीक है. So what you will see again, you will see ventricular septal defect. That is you can remember pro with a pulmonary, first of all pulmonary stenosis. Then what you will give? The right ventricular hypertrophy. Then what you will see? There will be the overriding of aorta. Then what other things you will see? There is a ventricular septal defect. So it will become PROV. PROV. Okay, so that is what you will see in case of the TOF, tetralogy of the fallout. Okay, rest what other things you will see? Increase APTT. Increase APTT seen in which condition? Increase APTT seen in which condition? In case of hemophilia. Okay, there will be increase of what? APTT. Now see here, as I told you, the all clotting factor disorders, like you have the fibrinogen deficiency, the all are what? Dominant condition. The only hemophilia is the only one that is what? X-linked recessive. Hemophilia is the only one that is your X-linked recessive. And your this is your in therapy question number 2 is also there. Here you will see if there will be the one platelet, there will be the PT, there will be the APTT. What is the prothrombin time? And this is what? This is what one? What we call it? Activated partial small a, activated partial thromboplastin times. So this is what very, very important. If we will be having the, like in case of thrombocytopenia. What is thrombocytopenia?
Low platelets count.
Decrease of what? Decrease of platelets count. So prothrombin time will be
Increase.
normal. Prothrombin time will be normal in just thrombocytopenia. Just remember the platelet will be decreased. But if it is the case of hemophilia, this is the case of hemophilia. What will be there? In hemophilia, platelets count will be normal. Okay. The PT will be normal. APTT will be on higher side. So APTT will be increased. That is means that is the case of hemophilia. If we will be having the seventh factor deficiency, remember this is seventh, okay, or you can write it, break it, seventh like that. So this is the not eighth. Eighth is what? Hemophilia. The seventh factor deficiency. Then seventh factor also we have the normal platelet level. Platelet level will not be affected, but the prothrombin time, or we will be having the APTT. That is the sorry, the prothrombin APTT will be normal. So in seventh factor, there will be opposite of what? Hemophilia. There will be the opposite of what? Hemophilia will be there. There is a one condition called disseminated intravascular coagulation. Disseminated intravascular coagulation. What will happen? Will platelet affected in this case?
बढ़ जाएंगे भाई, सॉरी.
The platelet count will be disseminated intravascular coagulation disorder. So they will be having the decrease of platelets. There will be the decrease of platelets, and prothrombin time and APTT will be increased. Okay. There is the vitamin K deficiency. The vitamin K deficiency. What will happen in vitamin K deficiency? The platelet count. No effect on the platelet. There is nothing related to the platelet. So vitamin K deficiency, the platelet count will be normal, but PT or APTT will be increased. Because there are vitamin K dependent factors. There are some vitamin K dependent factors. What are vitamin K dependent factors?
2, 7, 9, 10.
2, 7, 9, 10. So these are what? These are the vitamin K dependent factors. These are the 2, 7, 9, 10. These are the vitamin K dependent clotting factors. So clotting factors total कितने होते हैं? Total clotting factors
14, 13, 14.
कितने होते हैं? बाकी पढ़े नहीं रहे, बाकी उनसे क्या ही क्वेश्चन करने. कितने होते हैं? 13. कितने होते हैं? 13. So you can remember there are the total 13 clotting factors. So clotting factors you can remember with the help of clotting factors. You can remember with the help of foolish people, try climbing long slopes, try climbing long slopes. After Christmas, some people have fallen. Revise with me, speak with me. Foolish people try climbing long slope. After Christmas, some people have fallen. What is that? Foolish people try climbing long slopes. After Christmas, some people have fallen. Again, we will be having the foolish people try climbing long slope. After Christmas, some people have fallen. So what is F? F is fibrinogen. F is fibrinogen. P for prothrombin. P for prothrombin. Prothrombin. What will be the T? Thromboplastin, or we call it the tissue factor. Thromboplastin, or we call this as the tissue factor. Tissue factor. C4 we will be having, that is the calcium ion. That is the calcium ion. L for labile factor. L for labile factor. Sixth factor नहीं होता है. There is no sixth factor. So this is the fifth factor, and this is what? That is the seventh factor. This is the seventh factor, and this is what? Stored. Sorry, this is the staple. This is the staple factor. तो slope कैसा है? Slope है stable. Slope is stable. So you can remember it as the slope as a stable factor. A for, remember, we will be having the anti-hemophilic A. We have the anti-hemophilic A. Then we have the C4, we will be having the Christmas factor. What is known as Christmas factor? Which factor? Anti-hemophilic B. S4, remember, we will be having the stored power factor. S4 we will be having, that is the stored power factor. And P4, remember, we have the plasma thromboplastin. देखो, that P was thromboplastin, that was tissue, है ना? Tissue तो ये, this is what? Plasma thromboplastin. This is the plasma thromboplastin. H4, remember, Hageman factor. Hageman factor, Kalman syndrome. Okay, F4 we have the fibrin stabilizing factor. Fibrin stabilizing factor. Okay. So we have the, this is 8th, 9th, 10th, 11th, 12 and 13. Okay, 6 factor is missing. 6 factor, there is no 6 factor is there. Okay, so remember that 2, 7, 9, 10, they are vitamin K dependent factors. Factor 8 cause hemophilia A, factor 9 cause hemophilia B, that is also called the Christmas disease. And factor 11 cause the hemophilia C. Okay, there is a two pathway. One, we have the intrinsic and the extrinsic pathway. Intrinsic and the extrinsic pathway. तो इंट्रेंसिक एंड एक्सटेंसिव पाथवे कौन कौन से होते हैं? विच फैक्टर्स है इंट्रेंसिक एक्सटेंसिक? इंट्रेंसिक फैक्टर्स कौन कौन से होते हैं? विच आर इंट्रेंसिक फैक्टर? सो दे आर द 12, 11, 9 और 10. 2, 11, 9 or 10. 10th is basically that is the common for both the factors. Then we have the extrinsic factors. The extrinsic factor are the 3, 7 and 10. 3, 7, 10 or 8b, there is also intrinsic factors. Okay, that is you have to remember. So both having the common factor, that is the 10th factor. And remember that for the intrinsic factor, inside what we will do? Inside table tennis or we do the tennis? So inside what we will play? We will play the table tennis. So if PTT increase, so this is because of intrinsic factors. Extrinsic, remember, we will be having the PT will be increased. Now what is the 7th factors? What is the name of the 7th factor? 7th factors, what you have seen? So we are having the 7th factor. See here. That is the 7th factor. So 7th is what? That is what? Stable factor. So we will see the PT will be increased. And now if you will see here, that it belongs to which category? It belongs to the extrinsic factors. And in extrinsic, what will be high? The PT will be high. The prothrombin time will be high. And if these are the intrinsic factors in which they will see the PTT will be increased. If you see, they will be having the 8 factors, 10 factors or the 11 factor. Okay, or 9, 10, 11 factors. So they will be having the hemophilia A, B, C. The PTT will be high. Activated plasma thromboplastin time will be high. Okay, and in case of the 7 factor deficiency, PT will be increased. Vitamin K, remember, vitamin K, we have the 2, 7, 9, 10. And the 2, 7, 9, 10, they are present in the both. So PT and APTT both will high. Samajh aaya? Did you understand this thing? So in the, we have the 2, 7, 9. So they have the intrinsic factor also extrinsic. So both will high. In case of the 7 factors, only we have the extrinsic. So PT will high. Hemophilia, we have only the intrinsic factors. Intrinsic factors are present. So we will be having the APTT will be high. Other factors will be normal. And thrombocytopenia, as the name is saying, decrease of the platelets. So platelet count will be decreased. Okay. Now, contraindicated to the child. Which drug is contraindicated to the child? Which NSAID is contraindicated to the children? Which drug is contraindicated in the children?
Aspirin.
Aspirin. What is the name of aspirin? That is the acetyl salicylic acid. So remember that what you will see, that causing what? What is the side effect? It causes this syndrome, Rage syndrome. It causes the Rage syndrome. It causes the Rage syndrome. So Rage syndrome, it is a rare but serious condition that causes the swelling in the liver or the brain. Okay, and this is strongly associated with the aspirin use. Level of the sweat chloride. What we will see in the Rage syndrome? Swelling in the liver and in the brain. So there can be the edema of the liver and the edema in the brain. And there will be the hepatomegaly can also be seen. The level of the sweat chloride. See, what in cystic fibrosis we do one test. Which test is that?
Sweat chloride test.
Sweat chloride test. What is the level of the sweat chloride? 80 hai. What is the normal level? Normal is 10 to 20 millimole per liter. If 10 to 20, agar ye zyada ho gaya, if sweat chloride is more, then this is the what? cystic fibrosis. Acute glomerulonephritis, hypertensive syndrome, role of angiotensin 2. What is the role of angiotensin 2?
ब्लड प्रेशर बढ़ाना.
They will increase what? Aldosterone. They will having the effect on the aldosterone. They will effect on the adrenal gland, and that will release what? Aldosterone levels. And if the aldosterone, what they will do? They increase the sodium, more sodium. So if they will increase the sodium, what will happen? There will be the more hypertension effect. And if they will decrease the potassium, so if the potassium will be decreased, that patient can go to the or towards the acute kidney failure side. So that's why it causing the glomerulonephritis as well. Okay. The area of epidermis filling, SSS plus NS positive. What is NS positive?
Nikolsky sign positive.
Nikolsky sign positive. So Nikolsky sign positive in which case, which conditions? Nikolsky sign.
Pemphigus and by exfoliative dermatitis.
What is another name of this?
Right.
SSSS.
Writer's
Scalded skin syndrome करके भाई.
और किसमें होता है? This is positive in three condition. Which three condition?
Pemphigus and exfoliative or Reiter's disease.
So they will be having the pemphigus vulgaris. What is the pemphigus vulgaris? You see the autoimmune condition, blistering disorder. So there is the blisters formation where antibodies will attack the skin and the mucous membrane. Okay? So that is what we have this condition. After that, we will be having the 4S. 4S is the staphylococcal scalded skin syndrome. So this is condition caused by the toxin. Toxin from which organism? Staph aureus. From the Staph aureus. So the Staph aureus toxin will cause what? SSS. Then leading to, there will be the skin peeling will be there. The skin peeling, matlab Nikolsky sign positive. Then another condition is the toxic epidermal necrolysis. Toxic epidermal necrolysis. It is a severe infection to the medication, and that lead to the skin detachment. Okay. So positive Nikolsky sign that is the skin fragility. So skin fragility and the sign of epidermal separation or the peeling of or skin peeling at the level of epidermal. Like when you are peeling of the skin, it will peel out. Epidermal separation will be there. That is the Nikolsky sign positive. Child breastfeeding is there. So prophylaxis of the rectitis is recommended because what will be deficient in the child feeding, in the breastfeeding?
विटामिन्स में भाई
Vitamins. Which vitamin deficient?
K.
Vitamin K. And vitamin D. So vitamin D or vitamin K will be deficient. So okay, vitamin D, they contain breast milk contain very low amount of the vitamin D. Okay, so that's why if we are not given the prophylaxis for the vitamin D or without adequate sunlight, there is high chances of the rickets. The rickets will rickets will develop. So that's why you will give the prophylaxis of the rickets. Along with that, we have the vitamin K will be low in the breast milk. So newborn have the low store of the vitamin K. See, first of all, we give the, if we say which vitamin is very deficient in newborn, so we call it vitamin D, not vitamin K. See, vitamin K we are giving injection just after the birth. Vitamin K injection is given just after the birth. Why this injection is given just after the birth?
Because it causes hemorrhagic disease.
But normally what happens, if you see the gut alimentary canal of the newborn is completely sterile. Okay, so we having what? We have the useful microorganisms that is present in our intestinal microflora, and whenever we will keep having this baby will be having the breastfeeding, so this breast will go to the gut and then the vitamin K processing will start. So prevent any bleeding disorders in the starting, we will start with the vitamin K injections. But if you have there is no vitamin D source in the baby in breast milk as well, so that's why the vitamin D deficiency is more prominent and is a high chances of the rickets development. Okay, Then proteinuria, hyperproteinuria, and hyper. Okay, tell me before that, which vitamin is not seen in vegetarian? Which vitamin deficiency you will see in vegetarian people?
B12,
B3
B12,
and B12. Okay, so which one is that? Vitamin B12 will be deficient because this vitamin B12 is seen in the basically in the like non-vegetarian people like meat, mass, machi, and all this you see the vitamin B12. So in the vegetarian people you will see the vitamin B12 deficiency. So that's why if you will see in the most of the OPD, the doctors will recommend the vitamin B12 tablet, vitamin B12 injections, and the syrup of vitamin B12. In India, there are lots of everything. In all the medical store, you will see the vitamin B12 syrup, either multivitamins, and so all these things are very, very common because we are the more, like in more vegetarian countries, you will see the vitamin B12 deficiency. अच्छा नेफ्रोटिक है तो नेफ्रोटिक है तो क्या है व्हाट इफ नेफ्रोटिक इज देयर व्हाट विल कम इन योर माइंड ओ
प्रोटीन ज्यादा होगा 3.3
है ना तो oh my god will symptoms so proteinuria hyperproteinuria and hypercholesterolemia all those but patient will be having the edema decrease of what oncotic or osmotic pressure decrease or increase क्या होगा what will happen
decrease on
decrease oncotic pressures the GFR rate will be high ठीक है देखिए oncotic pressure decrease oncotic pressure patient having the edema the increase of the GFR or the patient will be having the proteinuria or we can say decrease of albumin. These all are the you have to consider it for the nephrotic. And nephritic what will happen? HO-HA. So HO-HA means
hypertension, oliguria, hematuria,
or A for
azotemia.
Azotemia. So what is azotemia?
Increase in urea, nitrogen in blood.
The increase of blood urea nitrogen. ठीक है. Khushi, please keep sleeping. Priti, keep sleeping. Have a good night. Then we have the next one. We are having the microspherocytosis, unconjugated bilirubin that will be very, very high. So this is seen in which condition? Yesterday we have seen. देखो microspherocytosis. What does it mean? देखो there is a tell me what is the anisocytosis and what is poikilocytosis?
भाई साइज और शेप चेंज हो जाना
हाँ किस कौन सा which one is size change? PP
पीपी एनिस्टोमोसिस में तो ये तो भाई पोइकिलो में तो शेप हो जाएगी चेंज और उसमें साइज
remember the PP ja so P for we have the poikilocytosis shape will change then we have the anisocytosis we will be having the anisocytosis we have the change in the size Z so there is a Z is coming and what is the microspherocytosis
कलर इंडेक्स साइज छोटा हो जाना कलर इंडेक्स कम हो जाना इससे
color index कम हो जाना what is the most microspherocyte basically we have the spherical shaped RBC है ना you are telling about the microcytic anemia ठीक है so there is a spherically shaped RBC will be there and normally what you have the biconcave but in this case we will be having the spherically shaped RBC will be there. What is the most common cause of microspherocytosis?
hereditary
spherocytosis. We have the hereditary spherocytosis. What is seen in hereditary spherocytosis?
spherical shape RBCs.
Spectrin and chirin or band cells. Spectrin and chirin band cells mutation will be seen. क्या होगा? Spectrin
Hemolytic disorder.
Microspherocytosis. The mutation होगा किसके केस में? Mutation in ankyrin, spectrin and band cell. Hereditary spherocytosis. You will see the patient will be having the anemia, the patient will be having the jaundice, splenomegaly, cholelithiasis, fatigue, paleness. What diagnosis you will do? What diagnosis? Peripheral blood smear, ठीक है, peripheral blood smear, you will see the spherical shaped RBC. You see the osmotic fragility test. Osmotic fragility test. So osmotic fragility test, what you will see, RBC are more fragile and they will break easily in hypotonic solutions. Okay, what is the management you will do? Folic acid supplementations, and or you can do the splenectomy, because their patient will be having the high amount of there is a enlarged spleen, splenomegaly will be there, so you will do the splenectomy will be done. 12-year-old girl taking 2 pills of aspirin. 4 hours later, body temperature 39 to 40 degrees Celsius, sudden rest, है ना? There is a red spot blisters, second degree burn, skin lesions, so erosive surface or epidermal peeling. Nikolsky sign is positive. This is seen in which condition? Acute epidermal necrolysis. What is acute epidermal necrolysis? तीनों अच्छे से समझाए हुए मैंने. What is acute epidermal necrolysis?
Steve Johnson syndrome.
नहीं, also known as the toxic epidermal necrolysis. ठीक है, toxic epidermal necrolysis. So remember that in the severe conditions, life-threatening conditions, what will happen? There is a skin detachment, and in this you will see the skin detachment will be very, very high, and there is a mucosal involvement infections. Here you will see the patient is taking aspirin. So aspirin, if you say that not directly associated with the TN, but other, जैसे like for example aspirin and other non-steroidal anti-inflammatory drugs, they can trigger the conditions that causing what the drug reactions, and due to that you will see the patient will be having the Steven Johnson syndromes and the toxic epidermal necrolysis. More commonly it is associated with the Steven Johnson syndrome, but here if you will be having a widespread second degree burn is there, so more conditions going toward the acute epidermal necrolysis, or we will be having the TAN. Okay, is that clear? And all the difference I already told you before that. Next, and which hypersensitivity is seen in the TN? That is the delayed type of hypersensitivity. You see the patient will be having the red macules. So that's why you will see the here the sudden red spots, the blisters will be there, and these blisters are of large size. They are not of the small size. So that's why we will be having this example, acute epidermal necrolysis. Lemon yellow skin with a fatty crust on the scalp. What is that? This is very, very difficult question for the group. बताओ. Is that disorder? Any disorders? अरे क्या पढ़ा तुमने? See, this is the one basically if you say that is the Krok disorders. So if you see the patient will be having the fatty crust on the scalp. Fatty crust on the scalp plus lemon yellow skin. That the crust will be looking like the lemon yellow, or they will look like the yellowish color. Okay, so that will be related to what we will be having condition called the JNS. So this is one disorder associated with the seborrheic dermatitis or the dandruffs. So okay, basically we can call this as the seborrheic dermatitis. If we see over the medical literatures, officials, this is not for the Krok, but seborrheic dermatitis we can consider it, or we in normal language we can call it the dandruff as well. Okay, if you will see there will be the overproduction of the sebums in the scalp, and that usually it is associated with one fungal infections called the malassezia. Okay, what the treatment you will give? Ketoconazole, selenium sulfide, and all these will be used. The intracranial birth injury plus we have the bloody CSF. Of course, that is CSF is bloody means which hemorrhage? Subarachnoid. In which condition you will see the CSF? In which space? In which space you will see the
Barren aneurysm,
barren aneurysm, and then intracranial birth injury also. So we will be having the, if you see the bloody CSF, the bloody CSF, it simply means we will be having, it's a, what does that mean simply? The bloody CSF. The bloody CSF means CSF having the blood. It means there is a blood in the subarachnoid space, and the subarachnoid space bleeding is known as what? Subarachnoid hemorrhage. That's it. 7-month-old body weight 3.4 kg. The protein will be 3.0. This is the easy question. That's why it's not written completely. For repeated questions. The history of angina plus edema of the face or the lower limbs. Urine of dark brown urates are there. Proteinuria is 1.2 gram per liter. What is the condition? Acute glomerulonephritis with nephritic symptoms. Okay, so angina is there, edema lower, the urine is brown, urates, protein. Urine brown means we will be having the hematuria is there, and proteinuria is also there. Sympathoadrenal attack. Sympathoadrenal attack. Suffer from vagitovascular dystonia of the pubertal glands. So what is that? The sympathoadrenal glands, what will give the propanol? The propanol, it is used as the anti-anginal drugs, or if somebody having the panic attack, anxiety attack are there, so we can consider the propanol as the treatment. And what is another name of the propanol is what? That is the Oxyden. Body temperature high, rash over the buttock and the lower limb, necrotic hemorrhage is present. What is that condition?
Meningococcemia.
Meningococcemia. So we have the necrosis, necrotic hemorrhage. We have the necrotic hemorrhage will be there. Okay, one condition we have seen that it is associated with one condition. If you see any hemorrhagic rashes also, no? If you see any hemorrhagic rashes are there, so that is also associated with what? Meningococcemia. Okay. If you don't know anything about the questions and not getting the answer, and if you're in the question, you're seeing the hemorrhagic rashes and option you are seeing the meningococcemia, mark the answer. Diagnosis of encephalitis, that is the chickenpox, severe premature baby, plus RI symptoms. What is the respiratory symptoms? Multiple skin extravasation, bloody foam from the mouth. What is that? देखो, severe premature. The premature के अंदर क्या होगा? What will happen in the premature? The lungs are not mature till now. अगर preterm baby है, तो it means the lungs will not be mature. Plus we have the respiratory symptoms. Multiple skin extravasation means we have the edematous conditions will be there. And a bloody foam from the mouth means there will be the some. What is the bloody foam? What is the meaning here? What bloody foam of the mouth? Basically, we can be having the some because of notes. देखो, if we are having any preterm, usually if we talk about the surfactant that is help in the lung maturations, so this will be usually start growing or the lungs start maturing at the age of which year? 34 weeks. 34 weeks onwards. And if the lungs, if the baby is premature, the preterm baby, or we can say the premature and the preterm, very tiny difference are there. The premature baby, when we call it, the baby gestational age is according to that, but the baby weight and the baby symptoms are not adequate for that gestational age. So we call it as the premature baby. Okay, so if we will be having such kind of the symptoms, what will we can see? There is a atelectasis, that means collapsing of the left lobe, left lungs or the lower lobe of the lungs will be affected. Okay, as in this question, it's already given this. On X-ray, what you see, the atelectasis of the lower limb and hemoglobin is 10. So what will be the disorder associated with it? That is the edematous hemorrhagic syndrome.
भाई एक बार एटिलैक्टेसिस के बड़े और छोटों में डिफरेंस बता दोगे एक बार?
एटिलैक्टेसिस के बड़े छोटों. Sporadic papillous elements on skin of the chest and back following the apple juice introduction. So initial tactic क्या होगा? Clarify, mother tight and exclude obligate allergens. ठीक है, if you are seeing the papillous element of the skin of the chest, it means causing it what cause? It causing the allergic reactions from the apple. So what you will do? Clarify. This is the some hygienic question or the social medicine question. So you what you have to do, if any fruit, any drug, any vegetable causing some kind of allergic reactions, like someone have the allergic to the milk and the milk product, some are allergic to the some citrazine, some allergic to the paracetamol, some are allergic to the diclo. So that's why you have the some drugs and the fruits and the some vegetables they are allergic to or specific. So if you are having the apple juice introduction, we are getting the some papular element means hypersensitivity are there. So clarify the mother diet and exclude the allergens from their diet. Temperature 40 degrees, swelling of the finger, ankle joint and the knee joints. What is that? Juvenile rheumatoid arthritis. What you will see in the juvenile rheumatoid arthritis? What kind of the stiffness?
Morning.
Morning stiffness. Okay, so joint pain, body temperature 38 is systolic murmur on apex, leukocytes, substantial proof of the rheumatisms. So in rheumatisms, they have studied the acute rheumatic fever, where you will see the complication of acute rheumatic fever. What was the complications? We have the carditis, in which we have the prolonged treatment of the benzathine penicillin. So that's why we will be having the systemic murmur are there and other related acute rheumatic fever symptoms. Then we will go for the what complication will be there, that is the carditis. Okay, this is completely explained in the rheumatology video. Okay, एक चीज करते हैं. See, if you see patient will be having like there is something like what one we having the pneumothorax. We having the pneumothorax. So pneumothorax basically what is that? That is the air in lungs. Then we having the hemothorax. What is hemothorax?
Water.
Hemothorax, blood or any fluid in lungs. Blood and fluid in lungs. So that is the hemothorax. Okay. Then hydrothorax, hemothorax, or we call it the hydrothorax. Hydrothorax, any fluid in the lungs, and we have the hemothorax, that is blood accumulated where in the pleural space, basically in the pleural space. We are having the pneumohydrothorax. Pneumohydrothorax. So pneumohydrothorax here होता है, that is air fluid level, air plus fluid. So I told you there will be the something like if we having the pleural effusion, if we having the pleural effusion are there, then what we will see, there is the dull percussion. You see there will be the dull percussion will be there, dull percussion. And will there be the tracheal deviation will occur in pleural effusion? Will there be tracheal deviation? No tracheal deviation. There will be no tracheal deviation will be there. After that, we have studied the atelectasis. The atelectasis, the lungs collapse. Again, you will see that lungs is collapsed. So again, you will see there will be the dull sound on percussion. Dull sound on percussions. And here you will see the trachea will deviate towards the same side. Trachea deviate towards same side. If it is the case of the simple pneumothorax, it is the case of the simple pneumothorax. That means air in the pleural cavity. So what you will see, there will be the hyperresonance sound. Hyperresonance sound on percussion. You have hyperresonance sound on percussions. Here, if you will see, there will be the no tracheal deviation, because this is the simple conditions. So there will be the no tracheal deviation will be there. But if you see, there will be the patient is having the tension pneumothorax. The tension pneumothorax. In case of the tension pneumothorax, remember the patient will be having the hyperresonance. Hyperresonance, again sound on percussion. On percussions. Then what you will see here, there will be the tracheal deviation away from the side of lesions. Away from side of lesions. In patient with the lobar pneumonia or the pulmonary edema, basically we see one radiological term, that is the consolidation. So if the patient is having some consolidations, like in case of the lobar pneumonia or in case of the pulmonary edema, what you will see? You see the bronchial breath sound. Bronchial breath sound. Here, one more thing that you will see, that is the late inspiratory crackles. Late inspiratory crackles, and along with that you see the dull sound on percussion. Dull sound on percussion. Will you see any tracheal deviation? Of course, no. So there is a no tracheal deviation will be there. There is a no tracheal deviation will be there. Okay, again we have studied that what is the resonance. The resonance we have seen, that is the hollow sounds. The resonance that we have studied, that is what? I'm just revising it because already we have studied this. Resonance is what? We have the hollow sound will be there. And again, if the hyperresonance is there, the hyperresonance is seen in pneumothorax. And in one more condition, that is the emphysema. In emphysema. Because in emphysema also we have the hyperinflated lungs. We have the hyperinflated lungs. So that again the air will be there, that will causing the hollow sounds. Okay, lung tissue density will be reduced, and the patient will be having the excess air. So if you have excess of the air, we will see the hyperresonance. If we will see the hyporesonance, that we will see in case of the pleural effusion. Pleural effusion, basically we have the fluid will be there that surrounding the lungs, so we will be having the decreased hollow sounds. Then we will be having the consolidation. If any consolidation is there, hydro or hemothorax. Hydro or hemothorax. So in that condition, we will see the hyporesonance. Or again, we can call this the decreased hollow sound, or we call it the dull sound. So that is the dullness will be there. There will be the dullness will be there. Okay, is that clear? So this is that you can remember. The next one. ECG, we see the hypertrophy of the right ventricle. The hypertrophy of the right ventricles, it is possible in case of the, what is the most common reason of right heart failure? Most common reason of right-sided heart failure. बताओ most common cause of right-sided heart failure.
पल्मोनरी एडिमा भाई.
Hypertension.
लेफ्ट हार्ट फेलियर भाई.
Left heart नहीं, right.
राइट में तो पल्मोनरी एडिमा.
Hypertension.
The most common reason of right-sided heart failure is left-sided heart failure.
भाई वही तो मैं बोला कि राइट लेफ्ट की वजह से राइट का होता है.
Pulmonary edema बोला तुमने.
नहीं, मैं बोला लेफ्ट वेंट्रिकुलर फेलियर की वजह से.
Sorry, I didn't hear. ठीक है, मेरी गलती होगी, सुना नहीं मैंने. ठीक है, most common cause of that is the right-sided heart failure. So that is what we are having the left side, that is the left heart failure. See, if we are having the left heart failure, what will happen in the left heart failure? First of things, there will be the pulmonary edema. Okay, if the left heart is not able to pump the blood will accumulate in the left atrium, that the blood will accumulate into the pulmonary vein, and that is causing the pulmonary edema. And again, the backflow will occur, and again it will causing the main thing that is causing the right-sided heart failure. Okay, you go fluid backup, and this fluid backup will increase the pressure in the pulmonary circulations. And if it increase in pulmonary circulation, then eventually it will lead to the right-sided heart failure, or the right-sided heart failure basically means the right side of the heart will work harder to pump the blood to the lungs, because already fluid are there. So that's why if already fluid are there, the right side will put the very high pressure, so will work very hard to pump that blood to the lungs, and that again eventually in the later on it will lead to the failure of the right ventricle. Okay. Other things are pulmonary hypertension, core pulmonale. So we will be having hypertrophy of the right ventricles. So this is one most possible, that is cause of the aortic stenosis. There are lots of other things are also associated with this question. That's not in here. So that is what aortic stenosis. Headache, fatigue, no movement, and the tendon reflex. So that is seen in which condition? Poliomyelitis. What is the temperature decline on which day? On in poliomyelitis, temperature decline on which day? That is
Fifth.
fifth day. Okay, temperature decline on the fifth day. If the soporous stage is there, patient have the meiosis. Plus, we have the asthenochoria due to typical intoxication with the following table and the drugs. So, what you will prescribe? है ना? चलो, tell me, did you practice this question? What is soporous state? चलो करते हैं. What is soporous state? बोलो. What is अरे सोपोरोस स्टेट कोमा स्टेज है क्या है?
नहीं पता है.
क्या होता है?
नहीं पता है.
अच्छा, मुझे लगा कुछ बता रहे हो. अच्छा अच्छा. So we will be having the soporous state. The symptoms of soporous state basically like if you have one stage of the coma stage. So before that stage we have the soporous stage, that is called like patient in the stupor or having some kind of the drowsiness. Not in the complete in the coma state, but in the drowsiness state. Meiosis basically where the pupils, the constriction of the pupils will be there. Asthenochoria means weakness or like abnormality of the pupils. Okay, it's occur. Why it's occur? Due to typical intoxication with the following tablet. What can be this tablet? It can be the opioid tablet, opioid poisoning, or it can be any sedative intoxications. Opioids like that, it can be due to morphine, due to heroin, it can be due to fentanyls that causing all these conditions. Other drugs that can cause these conditions are like we having the benzodiazepines, like the diazepam, lorazepam, alprazolam, and all these can cause. Other drugs we can give the barbiturates. The barbiturates can also cause these conditions. What are the barbiturate drugs? What are the barbiturate? Phenobarbital. We can do we have the phenobarbital. So what we will give in this, what are these drugs belongs to? Tranquilizers. The barbiturate drugs, benzodiazepines drugs, all these drugs belongs to which condition? That is the tranquilizers. These are anxiolytic drugs. Okay, the tranquilizer, if we say tranquilizers, we will be having the benzodiazepines, benzodiazepines, plus we have the barbiturates. Barbiturates. Okay, benzodiazepines like we have the diazepam, lorazepam, alprazolam, barbiturates, we have like phenobarbital, drugs and barbitol. So and other drugs that can causing such conditions, that are the opioid drugs. Opioid drugs like we have the morphine, fentanyl, heroin, fentanyl. So all these also can cause. But I think we have the option that that option we have the tranquilizer. So the answer will be the tranquilizer. They are anxiolytic drugs. And you also can remember the barbiturate, they cause the cerebral edema in the children. The Crigler-Najjar syndromes. So Crigler-Najjar syndrome, which condition will give? Barbiturates. Barbiturates will given in the Crigler-Najjar syndrome. What is the Crigler-Najjar syndrome? बता दो please. This is in your Krok questions as well. Crigler-Najjar syndromes. Which mutation are we? Just tell me which enzyme deficiency.
UTP, glucuronal transferase.
Uridine diphosphate gluconyl transferase enzymes. Okay, so we have the Crigler-Najjar type 1 and Crigler-Najjar type 2. So in the type 1, if you see, the patient will be having the severe jaundice will be there, and this absence of this enzyme will be there. The absence of the which enzyme? Uridine diphosphate gluconyl transferase. Crigler-Najjar syndromes. CNS लग रहा है. Crigler Najar syndrome. We will be having this is the CNS1. We will be having which enzyme? UGT, uridine diphosphate gluconyl transferase. So this enzyme will be deficient. If this enzyme will be deficient, we will be having the Krigler. This is the completely absent. Completely absent. Then we call this as a CNS1. Okay, what is the symptoms? The patient will be having the severe jaundice, yellowish of the skin, and bilirubin very high. If the bilirubin will be high, it can go to the brain. It causing the kernicterus. Kernicterus is what? The type of basically, or we can simply say the jaundice in brain, the type of the brain damage in which the hyperbilirubinemia will be there. Yesterday we have seen. Then we have what is the treatment for this condition? If they have the completely absent, the treatment, the definitive treatment, they have the liver transplant. Okay, but along with that, we can use the phototherapy also. So phototherapy, the blue light. If it is in the nursery, you see where the lots of the phototherapy people, condition are there because of this jaundice that help the manage the jaundice temporarily, but the permanent treatment again will be having the liver transplant. In CNS2, Krigler-Najjar syndrome 2, we will be having the partial deficiency. You have the partial deficiency of UGT. The partial deficiency of UGT will be there. Okay, what symptoms you will see? The mild jaundice will be there. That is appear later in the childhood or early adulthood. Okay, usually not seen in the newborns. The prognosis is better than the, of course, CNS1. This is having very good prognosis. And patient will be having sometime normal lifespan. We can start with the treatment like phototherapy. And after that, if some patient respond to the one drug, that is which one? Phenobarbital. We have seen that the Krigler-Najjar syndrome, bifurcates given only in this case. Which cases you will give? CNS2. The treatment for this condition that you can give, firstly you can start with the phototherapy that will help the temporarily. And if the phototherapy is not available, then we can start with the some phenobarbital. It having that it's very sensitive drug, so it's used. It's effective in very few people. If it is effective, then it's a very good drug for that condition. And if responding well, then it can treat the Krigler-Najjar syndrome too. So that's why you have to remember it inhibit the it induce which enzyme? That is the UDP, because we have the partial deficiency here. In this case, there is no enzyme is there. Enzyme is completely absent. So if enzyme is completely absent, we can't give the phenobarbital. Phenobarbital induce the UGT. UGT वहाँ पे है ही नहीं. There is no UGT. So there is no role of phenobarbital. ठीक है? Okay, there is one more disorder called Dubin-Johnson syndrome. Tell me about that. What is the Dubin-Johnson? we कर रहे हैं तो ये भी कर लेते हैं Dubin-Johnson भी. There is a Dubin-Johnson syndrome and one more disorders, the DR, doctor, the conjugated bilirubin. In which you see the, remember, Dubin-Johnson syndrome. It is the rare condition basically. ठीक है, not seen your, but this is a conjugation disorders. Like we will be having conjugated hyperbilirubinemia. In Krigler-Najjar syndrome, what will be there? There will be the unconjugated. There will be the unconjugated hyperbilirubinemia. Unconjugated hyperbilirubinemia. Here you will see the conjugated hyperbilirubinemia. So what will be there? Now this conjugated bilirubin, they will be like present in where in the accumulated in the blood streams. Okay, that making the blood very conjugated, and they will processed where in the liver, but they will not excreted out. Due to that, your patient will be having the severe jaundice and mild liver dysfunctions. This occur due to mutation in A B, C, C, 2 gene. A, B, C, C, 2 genes. Okay, that encodes on kind of the protein, and that this mutation in ABC2 gene, it mutate the proteins that is known as what we have the multi-drug resistant assisted proteins, and this protein is involved in transporting what conjugated bilirubin from liver cell to the bile for excretion. Usually what will happen in the liver, we have the processing of the conjugated bilirubin, but if this conjugated bilirubin accumulated in the liver only, then this condition will arise, Dubin-Johnson syndrome. Usually what happens, that conjugated bilirubin that convert from the liver cell into the bile for the excretions. Whenever any fat product will be, we are taking any fat product, so who will come? The bile will come to metabolize the fat products. But here we will be having the bilirubin, and this will not able to convert into the bile component. That's why we will be having the buildup of this conjugated hyperbilirubin in the liver, and that causing the mild liver dysfunctions and the jaundice in the patient. Okay? And also remember, if whenever you see the conjugated hyperbilirubin, you will see there will the dark urine will be there. The patient will be having the dark urine will be there. There is a one more test, that is the DR. You can remember the doctors are conjugate. Doctors are conjugate. So what does it mean? D for we have the Dubin-Johnson, and R for we have the Rotor syndrome. What is the Rotor syndrome? Dubin-Johnson, and R for we have the Rotor syndromes. They are what? Conjugated, means they will be the increase of the conjugated bilirubinemia. Okay. What you will see in the Rotor syndrome? Rotor. Again, this is the inherited disorders. What you will see in Rotor syndrome? Again, conjugated bilirubin. Conjugated bilirubin will be very, very high. Rotor syndrome, if you say the doctors, the DR, the D is coming first. So D is very, very severe condition. But if we talk about the Rotor syndrome is less severe than the Dubin. What you will see in the Rotor syndrome, there is a dark liver pigmentation. There will be the dark liver pigmentation will be there. Dark liver pigmentation will be seen in case of that. Okay, there is again the mutation will be there like LCO B1 or B3, but again that not been asked. So just remember, we have the dark liver pigmentation, that is very, very common things. Other symptoms that is usually seen in the conjugated bilirubin will be the same in case of the Rotor syndrome as well. Okay, here you will see the mild jaundice. In Dubin-Johnson, you will see the severe jaundice. Here you will see the less severe condition. Dubin, you see the more severe conditions. It having the good prognosis, Dubin having the weak prognosis. Okay, so that is what you have to remember. There will be the mild liver dysfunction in the Dubin. Here you will see the skin pigmentation, the dark liver pigmentation will be there. So remember that doctors are conjugate. So Dubin-Johnson and the Rotor, the conjugated bilirubin will be high, while in Krigler we will see there will be the high of unconjugated. There is a 50 one-handed glove, delayed falling of umbilical cord. So that is what congenital hyperthyrosis. Firstly, this baby is not very highly macrosomic, and the delayed falling of the umbilical cord. Usually, if you see the umbilical cord, what we will see? Umbilical cord, usually we have the two opening to cut just after 30 minutes. Okay, 30 seconds, sorry. We'll take the cap of the 30 seconds, and we call this is the hyperthyrosis. If the delayed falling of the umbilical, this is the direct terminology, that is congenital hypothyrosis. Next one, we will see the tracheitis. The tracheitis, you will see the wooden resonance. You will see the wooden resonance. Then you will have the leukopenia, the resonance, and the dry cough. These are the characteristic feature of the tracheitis. Okay. So we have the bronchiolitis. Bronchiolitis, what you see, the bandbox resonance. Bronchiolitis is very common in the children. See, bandbox resonance. Pleuritis, what you will see, the dry rails will be there. Bronchitis, you will see the resonance and the sputum, cough sputum. Obstructive, you see the wheezing. If any obstructive disorder, basically you will see the wheezing. Inspiratory stridor, you see in which condition?
Krok.
Group. That is the tri. Which one? Stenosing laryngotracheitis. Okay. So we will be having the tracheitis. You will see the trachea. There is an inflammation of the trachea. So after, if you see this condition, there is a vodal resonance. Bronchiolitis, bandbox. Pleurisy, dry rails. Pleurisy, you see the dry rail. Bronchitis, resonance, sputum coughs. Obstructive, you see the wheezing. Okay. So this is what you have to remember. Quincke's edema. What's the treatment you will do? Quincke's edema. Quincke's edema. पढ़ाया था ना मैंने Quincke's. There's a very there is a two kind of the edema, but firstly we have the Quincke's and another we have forward just. Quincke's edema तो होता है, that is the what we have the angioedema. ठीक है, there is a deep swelling of the deep layer of the skin. So if any such will be there, accumulation of fluid will be there. So what we will give, we'll start with the prednisolons. There is one thing that I forgot now. We'll call it. So then we have the T wave is discorded followed by complete compensatory force. So what is that? Trigeminal extrasystoles. Trigeminal extrasystole. What is the trigeminal extrasystole? Abnormal heart rate. Okay, it involves what? That is the trigeminal nerve. Okay, so that is the we having the basically the involvement of the trigeminal and we have the extrasystole. If in simple terms, if we say the trigeminal, you see there is a three wave pattern will be there. The T wave discorded followed by the complete compensatory force. Just remember that is what that is talking about the trigeminal extrasystole. Okay, such wording you will see in the Krok question only. Oligoaneuritic stage, we have the decrease of urination, extremities or numbness are there, reduced reflexes, respiratory disturbance are there, arrhythmia. So if you see the patient having the oligoaneuritic stage, I just told you the potassium high or potassium decrease, they both are having the effect on the kidney. So if the patient is having the hyperkalemia, there will be having the oligoaneuritic stage, the decrease in the urinations, or there will be the absence of the urinations. There the numbness will be there, reflexes will be reduced because of the more potassium. The patient will be having the respiratory disturbance and the arrhythmia will be there. The patient, if again the hypokalemia and hyperkalemia both causing the arrhythmia. Then we have the depigmentation, symmetrical affection of the skeletal muscles. What will happen? Atrophic cicatrice, this is the dermatomyositis. Okay, just take a 2-minute break or 3 minutes. बस थोड़ा ही रहा. So we have the oligoaneuritic stage, extremity numbness, reduced reflexes. So let's see here the hyperkalemia, hypokalemia. See, if you see about the hyperkalemia, or here we see the hypokalemia. What is the normal level of the potassium? What is the normal level of potassium?
3.5 to 5.5.
3.5 to 5.5. Okay, normal level is what? 3.3 to 5.5. 5.0 basic, sorry, 5.5 होता है हमारा, that is glucose. Okay, 3.3 to 5.0 milligram per deciliter. ठीक है, that is the normal level. If potassium level is more than 5.0, we call this is the hyperkalemia. And if it is what? That is less than 3.3, then this is the hypokalemia. You will see the arrhythmia. Here also you will see the arrhythmia. Because potassium, it is associated with the resting membrane potential of that, and it decrease the, if more potassium will be there, it will decrease the resting membrane potential of the cardiac muscles. So that will cause in the arrhythmia, in which you will see the irregular heart rhythms. There will be the irregular heart rhythm will be there. There will be the, if you see the other cardiac symptoms, you will see the patient will be having on the ECG, the peaked T wave will be there. The peak T wave on ECG. If you see the ECG wave is peaked, that is means hyperkalemia. That is the hyperkalemia. The patient will be having the bradycardia. The patient will be having the bradycardia, so slow heart rate, and the patient will be having the asystole. So asystole means the patient will be having the cardiac arrest will be there in severe cases. Okay, asystole means absence of the contractions. So peaked T wave, bradycardia, asystole. Seen in which condition? In hyperkalemia. Here you will see there will be the arrhythmia. The arrhythmia here will be due to PVC. What is the paroxysmal ventricular contraction? Or there will be the atrial fibrillation. We will call the atrial fibrillation, or the PVC will be there. And if you see the ECG, on ECG you see the flattened T wave. You will see the flattened T waves will be there. U wave, there are some U waves are there. If you see the prominent U wave, prominent U waves. Okay. Ventricular tachycardia will be seen in some cases, because this is a proximal ventricular contraction that causes what? Ventricular tachycardia. Other than that, muscle symptoms you can see, the patient will be having the weakness, muscles paralysis we can be there. Again, here again we will be having the, both increase and decrease, they both cause the weakness. Okay. Other condition that is associated with the nerve illness, we have seen the patient will be having the numbness. We have the tingling sensation. What is the tingling sensation? What we call this tingling sensation? मेरे पैरों हाथों में झंझनाहट सी हो रही है, तो क्या बोलेंगे इसको? Paresthesia. Paresthesia. What is the paresthesia? Basically, where in the extremities, upper extremities or the lower extremity, and here we will be having the same things. Okay, numbness, tingling sensation. Other than that, you will see the patient will be having the difficulty breathing. Difficulty in breathing. So patient will be having the dyspnea will be there. Again, here we will be having. Here we will see the due to in hyperkalemia, this is due to weak respiratory muscles. They will weak respiratory. Here, if you will be having the difficulty breathing due to hypokalemia, so they have difficulty breathing due to diaphragm weakness. The diaphragm will be weakened due to hypokalemia. So here due to diaphragm, or here due to weak respiratory muscles. You will see the patient will be having other symptoms: nausea, vomiting, abdominal cramping. This feature is can differentiate here. Patient will be having here the nausea, vomiting, and there will be the abdominal cramping. Here you will see the patient will be having the constipation along with that abdominal bloating. Because what happens? Slow intestinal mobility will be slowed down. Here you will see the abdominal bloating. Abdominal bloating. The causes again we have the, if we are having the hypokalemia can be caused by the diuretics. Diuretics like the loop diuretic, furosemide, Lasix. If you are having the more vomiting, more diarrhea, that can cause the hypokalemia. If patient is having the inadequate potassium intake in the diet, that can cause it. If patient having the metabolic alkalosis, that can also decrease the potassium level. And increase of what? Aldosterone level. All they are what the causes of what? Hypokalemia. But if we see the hyperkalemia will be seen in case of the acute kidney injury. If the patient is have the AKI, that can cause. If any kidney dysfunction are there, that can cause the hyperkalemia. The medications like potassium sparing diuretics, spironolactone, usually it is not caused because it's given for the potassium spare, but if it is given in the excess, that can cause the hyperkalemia. If this is ACE inhibitors, the ACE inhibitor, angiotensin converting enzyme inhibitors, that can also cause what? Hyperkalemia. Okay, and metabolic acidosis. This is you can remember. Otherwise, I know that all you can remember easily that according to concept wise. But one thing you can forget here, that is the metabolic acidosis, alkalosis. The alkalosis, ठीक है, अल्का के फॉर पोटेशियम, पोटेशियम को लो कर देगी, क्या कर देगी, पोटेशियम को लो कर देगी, पोटेशियम लो डाउन, अल्का एल के फॉर पोटेशियम लो लो कर देगी। मेटाबोलिक एल्कलोसिस क्या करेगी, पोटेशियम को लो कर देगी। और क्या होगा, मेटाबोलिक एसिडोसिस क्या कर देगी, पोटेशियम को हाई कर देगी। तो देखो यहाँ पे तीन फीचर याद रखो दैट यू हैव टू रिमेंबर फॉर द डिफरेंशिएटर, पीक्ड टी वेव, लैटेंट टी वेव, ब्रेडिकार्डिया, ब्रेडिकार्डिया, here the you see the prominent, क्या चाहता है ये, next only highlights, A systole, ठीक है। So here remember they are the A systole ventricular. So remember the ECG findings, arrhythmia दोनों में होता है, but the cause is different. Here due to irregular heart rhythm, here in hypokalemia due to PVC or atrial fibrillation. Then remember that weakness, numbness, all these are the same symptoms. ठीक है। The rest you have to remember that is here you will see the nausea, vomiting, abdominal cramping. Here you will see the constipation, abdominal bleeding. Vomiting is the cause of hypokalemia. But if you show the symptoms, which symptom, hyperkalemia का symptoms है. So constipation is what? The constipation you will see in hypokalemia because of the slow down intestinal mobility. The cause will be the difference. Here you will see the metabolic acidosis cause. Here you see the metabolic alkalosis cause. What other cause? You know the potassium sparing diuretics will cause the hyperkalemia. Okay, let me ask you that. Okay. Kosi, in hyperkalemia, in what you will see on ECG findings? Kosi, in hyperkalemia, what you will see on ECG findings?
Peaked T waves होगी.
Peaked T waves. So Ati, what you will see in the hypokalemia in ECG? The next we will be having the patient will have the deep symmetrical affection of the skeletal muscles. So that's what you've seen, the dermatomyositis. The dermatomyositis, this separate video are also there that of the dermatomyositis, in which you will see the weakness of the skeletal muscles are there. Then you have 3 year history of diabetes mellitus, hyperglycemic coma, initial dose of insulin that you have to remember 0.1 to 0.2 unit per kg of the body weight per hour. Baby born after the fast labors has palsy of the left hand muscles, ulnar nerves is there, the Klumpsky palsy that we discussed yesterday. Pain in the right hypochondrium after falling, after fatty or fried food. So you have the pain in the which chondrium, right hypochondrium. The positive scare or the omentis or the Murphy sign. So these are the signs that will seen in case of the chronic cholecystitis. Okay. Then we have the hand box resonance plus fine rails. So that is what band box basically. Band box resonance, bronchiolitis. Left elbow extended, forearm pronated. What will that? House palsy. Active movement, this is in the question itself, this is given. Left elbow extended, forearm pronated, that house palsy. Active movement, elbow joints are absent, the distal is affected. The active movement in the shoulder joints are pressurized, the proximal is preserved. So each point having the different words, each point having the significance. If the left elbow extended, forearm pronated, it's telling us that there is a house palsy is there. If in the question they have, after that the question says the active movement in elbow joints are absent. It means that if active elbow joints are affected, it means the distal part is affected. If they are saying active movement in shoulder joints are preserved, it means proximal there is a no problem. Proximal is preserved. Only the distal part is affected. Hand hangs passively, grasp and hand-mouth reflex. One's Klumpsky palsy. Okay. So if you will see here, the patient will be having the House and the Klumpsky palsy is present. Plus, there is only the distal part is involved and the inferior will be there. That the inferior distal obstetrical paralysis. Why this obstetrical? Because the region that present here is the obstetric region. That's why we call the inferior distal obstetric paralysis. In this question, they have not mentioned this, I think, but they have mentioned all these things. So based on that, you have to make the diagnosis: House palsy or the clumsy palsy. Distal is affected, proximal is preserved, and both options are there: inferior proximal obstetric palsy, inferior distal obstetric palsy. So you have seen the distal part is affected. अगर distal affected होगा तो क्या होगा? Distal obstetrical part paralysis. Child regurgitates small portion of the milk. Muscle tone is normal. What is that? Pylospasm. Okay, that is easy question. The same question, epidermal pemphigus. Hemorrhagic vasculitis, HSPA. That is hemorrhagic. What is the hemorrhagic HSPA? What is that? Inox colon
purpura.
Abdominal pain, red papillary hemorrhagic eruption, extensor surface around the gym. So we have the purpuric rashes are there. That is the HSP, vasculitis. Everything is discussed. Then the multiple vesicle filled with the seropurulent fluids. Okay, in region of occiput, neck or the buttock. So what are the seropurulent multiple vesicles? Multiple vesicles, we have the vesicle filled with the seropustule fluid. So we have the pustule, vesicle plus pustule. Some questions are answers. Okay, they have the answer is hidden in that question only. You don't have to think that I have not studied this medicine, I have not studied this medicine. Just or diagnosis. Maybe you have seen the diagnosis first time in the exam. Just read the question and make the diagnosis according to the questions. Like in this question, if you have never studied the vesicular pustulosis, you can still make it. The patient having the multiple vesicles, it means the vesiculosis are there. Filled with the seropurulent, means pustules are there. In region of occiput, whatever the regions, vesicular pustulosis are there. What you will say to the patients? Do not bath. This is the self-limiting condition, but the bath is contraindicated in this case. Okay. Negative reactions to peroxidase with the sudden black and the positive sign to glucose. So what is that? ALL. What will see in the ALL? See, AML are what? Peroxidase positive and MPO positive. But ALL are negative to peroxidase and the Sudan black. In AML, ALL is more common in the children having less than 10 years of the age. Okay, that you have to remember. White coffee skin, that is seen in the infection endocarditis. If blood in the urine, hematuria. So this question we have done in the part 1. If blood in the urine, hematuria is there. So we have the excretory urography. If there is VQ posterior, any walls problems are there, obstructions are there, then you do the micturating urethrophy. Okay? Is that clear? Clear. So this is what we have the pediatric basic revision. Okay. These both are the like some radiological procedures. It will check about if any obstruction are there or which is the first to examine. If you have in the question, if say if any obstruction are there, then which is the first to examine? That is the micturating urethrophy. Okay. From Krok point of view also, you can remember it from the from here. So like if any obstruction are there, then you can go for the micturating urethrophy. Or in the simple words, if in the question they will mention for the micturating, like the patient is urinating. Okay, this is procedure that is done when the patient is micturating. Urination is going on, and okay, it used to check about the urethra or for any other abnormalities. Excretory urography. In this, you will check about the kidney, ureterus, and the upper structure. The upper structure urinary systems, ureter, and urinary bladder. The focus will be kidney, ureter, urinary bladder, and here the focus will be the urethra, and the main focus will be the micturations. Okay. In both, what you will do? The contra here in this condition, if you say about the excretory urography, what you will see? You taking the urography. Urography matlab you are taking the image. You are clicking the photo. Here you will see the contrast. You will take the contrast, inject into the vein, where you will inject into the arm, and after that you will take the X-ray at the various interval and to track that contrast from where this contrast is going through the urinary system. Like for example, firstly it is coming into the kidney. So if it is a kidney and there is a stuck, the kidney stone is stuck in that ureter. So what, this contrast will not coming down. So if this contrast is not coming down, we can understand that this is what they have, the some of kidney stones are there. So this is what we have, the excretory urography. We can understand that patient will be having some kind of some obstruction due to stone or due to bladder stone, kidney stone, whatever. Okay, based on that we will evaluate the renal function. We will evaluate the any ureteral obstruction. If you have the ureteral, like you have the ureter, the ureteral obstruction we can check. We can check about the hydronephrosis. Like if there is any fluid are there, any water accumulation are there in that region, so we can check out. In case of the micturating, what you will check about the VU key or urethral stricture. If in urethra, if you find some kind of the narrowing or the strictures are there or the blockage are there, then you can check out the micturating urethrography. If any trauma to the urethra, you can check with the help of micturating urethrography. In children, we will be having the recurrent UTI infection sometimes. So what will happen? The possible reflux of there or abnormal urethral, abnormal reflex or possible reflux or the abnormal urethral function you will see in case of the micturating urethropathy. ठीक है? Is that clear? Understood? So excretory upper
भाई एक
urethral.
क्वेश्चन था 2025 में कि बुकलेट में कि ब्लैडर इंजरी से में एक्सक्रीटरी यूरोग्राफी करते हैं, तो वो कैसे?
ब्लैडर इंजरी में एक्सक्रीटरी यूरोग्राफी, हाँ तो ब्लैडर इंजरी में हम एक्सक्रीटरी यूरोग्राफी कर रहे हैं ना. देखो वहां पे हम क्या कर रहे हैं, हम वेन्स उसमें हमने क्या करा, वेन्स के अंदर हमने कॉन्ट्रास्ट डाला. ठीक है, वो वेन जो कॉन्ट्रास्ट वो क्या होगा, किडनी की तरफ मान लो एक्सक्रीट हो रहा है, तो किडनी से वो चला जाएगा यूरेटर के अंदर, यूरेटर से वो यूरिनरी ब्लैडर के अंदर आके फंस जाएगा. ठीक है, और डिफरेंट डिफरेंट ट्रैक, जैसे जैसे हम कॉन्ट्रास्ट को ट्रैक करते जाएंगे, हम पिक्चर क्लिक करते जाएंगे. तो जैसे हमने पिक्चर क्लिक करी, तो अगर वहां पे कोई भी ब्लैडर, जैसे फॉर एग्जांपल सपोज किडनी इंजरी है, तो किडनी इंजरी हुआ तो वहां पे कुछ क्या होगा, कॉन्ट्रास्ट का मिसमैच दिखेगा. यूरेटर के अंदर कोई भी अगर ऑब्स्ट्रक्शन हुआ तो क्या होगा, कॉन्ट्रास्ट वहीं पे रुक जाएगा. ठीक है, ब्लैडर के अंदर कोई भी इंजरी हुई या कोई भी ट्रॉमा हुआ तो उस जगह पे क्या हो जाएगा, वो कॉन्ट्रास्ट उस जगह को नहीं गेन कर पाएगा. ठीक है, तो इसके बेस पे हम इसको डिफाइन कर सकते हैं ब्लैडर इंजरी. और मिक्चुरेटिंग यूरेथ्रोग्राफी अगर हमें करना है तो हमें बेसिकली यूरेथ्रा, लोअर यूरिनरी ट्रैक्ट में बेसिकली हमारे पास यूरेथ्रा, अगर कोई भी स्ट्रक्चर प्रेजेंट है जो कि बहुत कॉमन होता है यूरेथ्रा के अंदर. ठीक है, कोई भी स्ट्रक्चर बेसिकली स्टेनोसिस, एक नैरोइंग हो रखी है, और वहां पे एक वॉल होता है जिसको हम बोलते हैं वीयूके वॉल, वेसिको यूरेट्रल रिफ्लेक्स वॉल. ठीक है, वहां पे क्या होता है, रिफ्लेक्स होता है. अगर वो रिफ्लेक्स वापस हो रहा है, मोर रिफ्लेक्स हो रहा है, तो उसके केस में भी हम चेक कर सकते हैं कि मतलब पॉजिटिव आएगा, मिक्चुरेटिंग यूरेथ्रोग्राफी पॉजिटिव रिजल्ट आएगा उसका. ठीक है, सो दैट इज द डिफरेंस. मिक्चुरेटिंग मतलब मिक्चुरेशन करते वक्त, एक्सक्रेटरी मतलब कि हमने एक्सक्रीशन करते वक्त हमने पिक्चर लिया. एक्सक्रीशन करते वक्त अगर पिक्चर ले रहे हो तो एक्सक्रेटरी यूरोग्राफी, पेशाब करते वक्त अगर पिक्चर ले रहे हो तो मिक्चुरेटिंग यूरेथ्रोग्राफी. ठीक है, चलो ओके. सो थैंक यू फॉर दैट गिविंग योर टाइम्स. होप यू आर नो स्लीपिंग.